Hello, my name is Joe Ball. I am proudly a transgender man, and I am the CEO of Switchboard. Switchboard runs a dedicated national LGBTIQA+ suicide prevention program. We also specialise in family violence prevention, mental health, and the relief of social isolation in all our communities. I would like to open today's panel on community responses to mental health challenges with an acknowledgement of country. I'd like to thank the traditional owners for their warm welcome to country this morning, and I wish to respond with acknowledging that we are on the lands of the Gadigal people of the Eora Nation. I acknowledge their ancestors past and present, and all Aboriginal and/or Torres Strait Islanders joining us today, both here in the room and online. Because we're talking about mental health and suicide today, I want to acknowledge the ongoing and intergenerational trauma caused by invasion, dispossession, and attempted genocide. To close the gap on mental health disparities in Australia for First Nations people and to meet the challenges, including for those who are LGBTIQA+ and sister girls and brother boys, we must address our past and hear the truth. Together we can end institutional discrimination, the over-incarceration of Aboriginal children and adults, poverty, barriers to education, constitutional recognition, and land and sea rights. It's important to remember that diverse genders and sexualities existed on this continent before European invasion in 1788. It was with British colonisation through a British law that homosexuality was for the first time criminalised, which included, for consensual acts between men in this state, New South Wales, a life sentence in New South Wales up until 1924, and the death penalty in the state I'm from, Victoria, up until 1949. The project of decolonisation impacts us all. Today, we will be talking about mental health and suicide, and some of you might find some of the content challenging and upsetting. And that is okay, but I do ask you to think about whether participating by sitting through this panel, both here in person and online, is the right thing for you today. And for those of you who can stay in the audience and online, I encourage you after this discussion to do something to reconnect with things that make you feel hopeful. Perhaps this could be going outside for a walk, patting your pet, texting a friend, or connecting with a local helpline. If you're based anywhere in Australia, you can call Q Life or Beyond Blue, and if you're in Victoria, you can call Rainbow Door. It is my pleasure to now introduce our first speaker, Mark Butler MP, the Federal Minister for Health and Aged Care. Minister Butler is not new to the role or to the issues and challenges around addressing mental health and social exclusion. Like many of us in the room today, he has been an advocate and leader in this field for several years. Back in 2007, under the leadership of Australia's first ever female Prime Minister, Julia Gillard, Mark was appointed Australia's first ever Minister for Mental Health. In previous administrations, he's also held the ministries of housing, homelessness, social inclusion, climate change, water and the environment. These are all pertinent social determinants of poor mental health and drivers of suicide. If you could please join me in welcoming to the stage and to World Pride, the Minister for Health and Ageing, Mark Butler.
Well, thank you, Joe, for that acknowledgement of country, but also for that really warm welcome. Can I say, after 3 days in Canberra, what an absolute delight it is to be here. It's not just because I'm not in Canberra, but the buzz, the vibe, the energy here is just extraordinary. Sydney is a wonderful place to come together. I know there are going to be challenging and occasionally distressing conversations, including at this panel, but the sense of hope and energy and resolve already that I've noted from World Pride is just a breath of fresh air. So for those of you who aren't Sydney-siders, if you come from elsewhere in Australia or from overseas, welcome to this extraordinary town, and I wish you all the best for the rest of the conference. About 11 years ago, I had the privilege of walking out the front to a crowd of several thousand people and announcing that the Labor Party had finally changed its policy on marriage equality. Many of us have been fighting for that for years, including our now Prime Minister, who I think marched in his 35th Mardi Gras on Saturday night, the first as Prime Minister. It was then a long road to get actual marriage equality into law, And I know it was really painful. It was distressing. No other group had had to put their relationship to a national plebiscite, in spite of the result being so beautiful and affirming and healing in many ways. The process was really damaging and caused a whole lot of people enormous distress. And it reminds us that even with positive change, the LGBTIQA+ community continues to feel the brunt of stigma and prejudice and violence. And that drives poor health, not just poor mental health, but poor health very broadly, and something we as a new government are really conscious about. It also reinforces that we don't have enough services that meet the needs of the LGBTIQA+ community. I was asked by Joy FM upstairs, what does equality mean? Equality doesn't mean the same. Equality doesn't mean a cookie-cutter approach. Equality means giving everyone a service that meets their needs, and those needs across the community will be different, including for your community. We know that outcomes for LGBTIQA+ Australians, particularly mental health, which we're going to be talking about over the course of this panel, are not just worse than the national average, but they're significantly worse, and right through the life cycle. We know how poor the mental health, particularly of LGBTIQA+ young people, particularly trans and gender diverse young people, is, the appalling rates of mental distress, suicidal ideation and suicide, how appalling they are. And although we have models of care, Headspace, many others online that simply didn't exist 3 decades ago, they're not meeting the needs. There's just not enough supply of those services to meet the needs, so we've got to do better. But it goes right through the life cycle. One of the really powerful moments I had as the Minister for Aged Care more than a decade ago, going around the country, was this big town hall meeting of several hundred people in Wollongong. And an old guy who was well into his 80s, would have been born in the 1930s, so a pre-boomer, stood up, got the microphone and said, "I've never told my community this, but I'm a gay man, and I don't have confidence that the aged care system is going to work for me." And the round of applause from his community was beautiful, but it reinforced to us that a sector, particularly delivered by church services that had shown LGBTIQA+ people so much stigma and discrimination for so long, could not deliver aged care services that met that generation's needs, particularly a generation that, because they were subject to the possibility and reality of prosecution, were often quite closed about their sexuality. What that said to me is we needed to talk with LGBTIQA+ elders. We worked with LHA and we developed the first ever ageing strategy for your community. The first ageing strategy that dealt with intersex issues, I was told, on the planet. And it not only allowed us to remove the religious exemption for those aged care providers, a religious exemption that I know is still a contested position across other services. It allowed us to make that legal change, but it also allowed us to change the culture of aged care services. And we want to do that across health. There's so much more to do, which is why I'm so proud of the work that Jed Carney has been doing with the FAO and with LHA and other organisations to kick off a process to build with your community a 10-year action plan across the health sector, not just in aged care, but across the health sector. And I'm confident that although that's just the beginning of the journey, that will lead to a much better understanding about how we close those disparities, how we build better services that meet the needs of the LGBTIQA+ community. I was also really delighted that Jed was able to announce today $26 million into medical research, particularly on these issues, working with community as well. So I wish you all the very best for this terrific conference. I'm going to stay for this panel, which I'm really interested in. As Joe said, it's not going to be easy, but it's an important discussion, a really important discussion, which you know better than I just want to leave you with this. You will have seen a number of members of our government here over the last couple of days, and will be here over the next couple as well. We are a government that deeply, deeply wants to work with you. We have a great tradition of doing that, going back decades. Now, it doesn't mean we've always got everything right, but we are deeply committed to making sure that the next several years are years in which we can work in true partnership. Thank you very much.
Thank you, Mark, and I want to recognise that the 10-year plan that's been released, and not just a plan, but a funded plan, and we all have a role to play. I do want to make it was something really to have the first Australian Prime Minister march on Saturday night in Mardi Gras. That being said, Malcolm Turnbull attended it for many years, but he did not march. And it was really something for the first Prime Minister of Australia to march, and it marks a moment. But it also drew attention to the fact that if a teacher from a faith-based school had marched on Saturday night, under the Religious Discrimination Act that is current, they could have been sacked by Monday. And so that's my reflection. It shows us how far we've come and how far we have yet to go. So today we are talking about a community response to mental health, and the panel here with me today is, and I'm going to introduce the panel, is Bonnie, is an intersex woman, peer worker, systematic advocate working with and within the intersex community to advocate for legislative protections and improved access to affirmative rights-based health and mental health services. Bonnie nurtures intersex community connections and a burgeoning intersex peer workforce. She is the designer of InterLink, a peer-led and community-based intersex psychosocial support program, and is one of the original signatories of the Darlington Statement, in Aotearoa, New Zealand, an Australian intersex community consensus statement. If you haven't looked at the Darlington Statement, you should. Bonnie, and you should sign it. Bonnie advises government and NGO on intersex issues and is an intersex educator, developing affirmative practice resources and regularly providing a sector-specific training through the Yellow Tick initiative. Welcome, Bonnie. Dr. Todd Fernando is a descendant of the Kalari peoples of the Wiradjuri Nation and identifies as queer with the pronouns he, him. Todd is the Victorian Commissioner for LGBTIQ+ communities, the second person to fill this groundbreaking position. In this role, Todd provides high-level strategic advice to the Victorian Government on the development and implementation of policies, services and programs to meet the needs of LGBTIQ+ communities. Todd completed his PhD in medical anthropology with the University of Melbourne and is a leading expert in reforming social policy and cultural safety frameworks in a public and private sectors across Australia. Todd is recognised as a strategic thought leader with a commitment to improving outcomes and opportunities for all Australians. Dr. Michael Gardner is a gay man Buddhist community leader and the head of the National Suicide Prevention Office, a specialist unit created to assist Australian governments and implement a more comprehensive and coordinated national approach to suicide prevention. Michael has a PhD in natural sciences at Cambridge University, where he subsequently pursued an academic career and remains an honorary fellow. I know that was a bit faux pas, wasn't it? Michael, I think you are an honorary queer as well. Michael has worked in the not-for-profit sector and for the Australian Public Service before serving as the Australian Government's Senior Advisor for the Mental Health and Suicide Prevention Minister from 2018 to 2022. Michael's work in suicide prevention draws on this diverse career in research, community support and public service, and is informed by his own extensive lived experience of childhood adversity, mental illness and suicidality. That's Michael. Before I throw to our impressive panel of experts, I want to set the scene a bit for the conversation we are about to have. In 2020, the Private Lives 3 report was published. This report is the most comprehensive and diverse study to date on the mental health and well-being of LGBTI+ people living in Australia. We would love to see a Private Lives 4, if I could put a pitch in for that, which maybe could be funded through the recent research announcements. Devastatingly, this report found that LGBTIQ+ people have twice the rate of homelessness than the general population. 1 in 10 LGBTIQ+ people have experienced sexual assault in the last 12 months to the study. That LGBTIQ+ people have much higher rates of mental health challenges, particularly depression and anxiety, and high and very high levels of psychological distress, as well as suicidal ideation and suicide attempts, than is observed in studies of the general population. Less than 50% of us have private health insurance. 1 in 4 LGBTIQ+ people have considered suicide attempt in the 12 months prior to the study, 20 times higher than the general population. I just want to pause for a moment because of that stat and realising that that is so many of us in the room, and I want to acknowledge that, how painful these statistics are, or people that we know. Almost 3/4 reported having made a serious suicide attempt in their lifetime, 4 times higher than the general population. Nearly half of all transgender people in Australia have attempted suicide in their lifetime. People living with an intersex variation experience high levels of discrimination in healthcare settings. Participants with an intersex variation also reported high levels of suicidal ideation and attempts, psychological distress, and low levels of feeling accepted by family or in healthcare or other mainstream settings. High proportions of LGBTIQ people reported in the study that they would prefer to use a service that is only and specifically for the needs of LGBTIQ+ people. In another study just on transgender adults, shockingly, 33% of trans people reported discrimination from employment as a result of being trans, and the unemployment rate of 19% was more than 3 times the national rate. Of course, this is all against the backdrop here in Australia of significantly increased legal rights since national discrimination of homosexuality, which was as late as 1996, marriage equality in 2017, and now there's even increased protections coming into effect next month in the Fair Work Act. These statistics and milestones are very familiar to my panel, and I would suggest many in the room. So my question to open today's panel is, how is it that as an LGBTIQA+ communities, we do have the most rights that we have ever had post-colonisation, and yet suicide rate remains high and mental health outcomes continue to be staggeringly poor? Not an easy question. I'm going to throw to Michael.
Thanks. Yeah, I'm glad we're starting with the easy questions. So I think the reason why the rates remain high from my perspective is that we are framing the issue of mental health and suicidality incorrectly to begin with. Our current approach regards mental illness and suicidality as primarily an issue for the individual, and the solution, therefore, is to intervene to build the inner capacity of the individual, usually through some sort of clinical intervention. But this approach is destined to be ineffective for the simple reason that it doesn't acknowledge or address the real causes, in many cases, of mental illness and suicidality. We have understood in so many other areas that human beings are really the product of their biology, their psychology, and their environment. Similarly, mental health and suicidality are more about the relationship between the individual and their context. I'll give you some statistics. Either you've spoken about some statistics, but I'll give you some more around suicide. In Australia, 48% of suicides can be attributed to 3 modifiable factors. That's child abuse and neglect, alcohol and drug use, and intimate partner violence. Child abuse and neglect in particular has been the leading risk factor for suicide for the last 20 years and accounts for between 1/4 and 1/3 of all of the years of healthy life lost to suicide. Domestic violence doubles the risk of suicide. In Western Australia in 2017, half of the women and children who died by suicide have been victims of domestic violence. Low income, unstable income, homelessness, and unemployment each double the risk of suicide. And these are compounding factors. Social isolation and disconnection increase the odds of a suicide attempt over the lifetime by 3.5 times and increase it by 17.5 times in the previous 12 months. Now, all of these factors are more prevalent in the LGBTIQ+ community than in the general population. So don't get me wrong, I'm not saying that mental health treatment is not needed. It is absolutely essential and an ethical imperative. And there are people who, through biology or genetics, have severe and complex mental illnesses, organic mental illnesses, that are not driven by any other factors. And yes, for them, mental health care must be the cornerstone of our approach. But we have to recognize that no amount of mental health treatment is going to fundamentally change outcomes for individuals if they are returning to situations of abuse, violence, financial instability, or homelessness. So we need to turn our attention to the socio-economic factors that are actually the causes of mental illness and suicidality. We need to build safe and inclusive societies. We need to combat stigma and discrimination. We need to provide stable income, employment, and housing. And yes, we need to provide mental health care. This more holistic approach is ultimately a more ethical, more compassionate approach, and is more aligned with human rights. And because it seeks to prevent people from becoming unwell in the first place, rather than waiting for them to experience diminished well-being before intervening. So it's a long answer, but in short, I think it's because of our very narrow, individualized, medicalized perspective of mental health and suicidality that we, no matter how much we invest in mental health, it simply cannot turn the tide.
Yeah. And one way my most grab line about this is it's not because of who we are, but how we've been treated. And unfortunately, we have to still contest that point. It should be obvious. But I'm going to throw to Todd for your reflections on the question.
We don't wake up in the cot hating ourselves as babies. It's absolutely something that we are aware of as we grow up, whether it's visually not being picked on a certain sporting team, if it's comments made by cousins or family members, teachers, if it's not seeing ourselves reflected in media, on TV, or if mum or dad gets awkward when there's a gay kissing scene, you know, and you're watching it and how awkward that experience, you know, those are really what seem like mundane experiences that dig deep into our psyches, that say to you, oh, you're not enough. That's not normal. You know, so it's all of these compounding kind of things that we witness as LGBTIQ plus people growing up that don't reflect the world in which we're trying to exist in. But we know that that is made more complicated by culture, by race, and where you live. I grew up in a small country town called Condobolin, also made popular by Shannon Noll. That's where he, you know, so. But growing up, there was virtually zero representation that looked like me in terms of my queer identity. And so I was forced myself to leave in order to search for what else was out there. And that's a journey that many queer people or trans and gender diverse people from regional rural areas do in order to seek protection. So we're forcing ourselves to go to places in order to see ourselves reflected, because where we aren't reflected, we know is not safe.
Thank you. And I'm getting flashbacks to watching movies with my parents during that. Yeah, but thank you so much. And I wanted to turn to you, Bonnie, to just talk about what you see as the drivers of poor mental health for, you know, I guess the proposition that I made about we've got some of the most rights that we've ever had, which I don't think is the same for the intersex community at all, but has more rights than ever. I mean, please, your reflections on this.
Well, I often think that, you know, in terms of human rights, when you're trying to advocate for them and you don't have them, you're below par, so you're at zero. And you're just surviving. And actually, when you start to get human rights, that's the ground that you can then start thriving from. But if your community is not well known or not understood, if if policymakers, social service policymakers and services don't actually understand what intersex is or what how that presents, and people have to continuously educate service providers and medical professionals just to receive basic services, then this really stacks the cards against them in terms of actually accessing the types of supports that they need early on, so that they can like mitigate some of the pressures that come and that build. So I suppose in terms of narrative arc about how many intersex people's psychosocial impact goes over their lifetime. So if someone is born with sex characteristics that are visibly different from what is typically considered male or typically considered female, those types of bodies are still incredibly pathologized within a Western medical model. And we still see irreversible and non-consensual medical interventions occurring for people to ensure that those bodies look or functions in ways that are more typically male or typically female. So we're talking at more than 46 known diagnoses or variations. So being told that your body is from a very early age wrong and needs to be fixed, even though it's otherwise might be healthy, or the types of those characteristics might otherwise be healthy, is deeply stigmatizing. It also erases intersex. It seems to position it as something that is fixed and doesn't require lifelong integration in terms of the social systems that people engage with. And many of those interventions are based on psychosocial rationales about protecting people from the threat of the stigma of being different or bullying potentially at school. So it really individualizes the stigma as shame within people, which then they have to go and live within their lives. They're isolated, they're not provided any psychosocial supports, they're not integrated with community, so people don't have language to talk about it, so they don't know how to express what has happened to them, they don't know how to advocate on their behalves to be able to actually be seen, be known, or seek justice if that is what they do. And often, sometimes when people do start to get connected with community, they do recognise the things that have happened to them in their lives and recognise that they were human rights violations because they happened without their full and informed consent, then that's when people start to mobilise to try and change those systems. So as someone that's run peer support groups for many years, we were driven to systemic advocacy to try and change the systems that are still doing harm, because we were constantly hearing the same types of stories that came up from people, the stories of isolation, of shame, of family cultures that didn't know how to manage this, parents that didn't know how to disclose to their children that they had an intersex variation, and then the difficulties about engaging intimately with people when you're completely disconnected from your own body and your bodily autonomy is completely taken away. So all of those protective factors that come from having loving and supporting relationships, being open and transparent with your friends, they're all impacted. So yeah, and again, many intersex variations actually only become apparent at puberty, when puberty doesn't happen in a way that was expected or happens in a way that wasn't expected. And that can have a really massive effect as well, particularly because many of the health services that are offered to people with intersex variations are offered free in a paediatric setting, but are highly costed in a private adult healthcare setting. So there's a real push to get people through a paediatric healthcare thing, and if they're in high school and you know, at 16, and they get this diagnosis and then have to be forced through this, it really has an impact in terms of their education, in terms of their social identity, in terms of how they see themselves in the world, and that can have lifelong implications in terms of education, you know, potential to earn money and access ongoing health services as they get older. Particularly if they've had a negative experience. You know, if you've had a bad experience with a healthcare provider, you're much less likely, well, you're never going to be followed up for like follow-up long-term data collection, so you're completely lost to medical follow-up, but you also might really not look after your own body because you don't trust medical professionals to see you and address your needs.
And then you're going to tell somebody else in your community who's not going to go to that service,
Yeah.
because the grapevine of, oh no, don't go to that service, they're not welcoming, is so loud and so persistent.
Yeah.
Sorry.
Yeah, and that, I mean, just to quote another study, but Understanding LGBTI Lives in Crisis, which is now a little bit old, but I'd say it's my favourite study, partly because it's done with Lifeline and Q Life. And the thing about that study says that actually we know about the services. Like, we know that Lifeline exists, we know that helplines exist, but we are concerned about their readiness to have the conversations we need to have to improve our mental health and well-being. And that's not anecdotal, that's me talking about what's in that study. And I think there's a lot of work to be done in that space. And I'm hearing from all the panellists also a theme about families. So we've got we need to improve the service response, but we also need to look at families. And I think that's a difficult thing for LGBTIQA plus people, because we've gone on a journey of a lot of the time of going away from family. But the evidence does show that the protective factors, there are strong protective factors if your family is accepting. And of course, if your family has literacy around intersex, that is an extremely protective factor. So the minister brought up marriage equality, and I do want to shift to that briefly, because I think that it is there was such a thing that it was posed to us. I don't think anyone here thinks this, but it was posed to us the question that this is the final thing we needed to get done. And of course it wasn't, for all the reasons we've talked about on this panel already. But what we do know about marriage equality is that it caused, talking about families, a lot of issues that we are still living with as a community. And these big public debates about our life, and of course, in the case of marriage equality, we didn't need to have the postal survey. But I want to turn to Todd for your reflections on, and with your permission, about with marriage equality and that public debate, and this year we're going to see The Voice. All things progressing. And what that will look like, I guess, LGBTIQA plus people who are Aboriginal and Torres Strait Islanders.
Yeah, look, at the outset, I think it's an important next step for Australia to recognise formally Aboriginal and Torres Strait Islander people in the Constitution, as well as afford them a voice to simply comment and advise on the designs of policies. As LGBTIQ plus people, we know how important a yes can be, and the message is that simple. That for 2 centuries now, Aboriginal people have been seeking ways in which to create a sustainable relationship with the government, and I think this next step is really important. Central to that, however, is to remind ourselves that the feelings that we all went through as LGBTQ plus people, where our lives were up for debate, the people who we loved were up for debate, is going to happen again for another group of people in Australia. For LGBTQ plus Aboriginal folks, that's twice now that their lives will be up for discussion, that their connection to community, to kin, to country is up for discussion. It will be horrendous. The cultural war that we're about to embark on, unfortunately, because some people in community don't see the sequencing as correct, which I'll leave it as that, but nonetheless, it's going to be lives, vulnerable black, queer and black trans and sister girl and brother boy lives on the line that will inevitably also spill over into our queer and gender diverse brothers and sisters across the region, our Takatapuis, our Whawhawhenais, who will inevitably have to witness the extent of people saying, oh no, not you. And that flow-on effect is going to be really, really devastating for communities who just want a fair go.
Yeah, I just want to comment on that, and I have to be careful as a public servant, but from my perspective, given we were talking about mental health and suicide, in the most reductive analysis, suicide can be considered as a diminishment of agency, identity, safety, health, and social inclusion. And in that light, I don't know whether The Voice is going to practically change people's lives. But I do genuinely fear that a no vote will result in the loss of an enormous number of lives. And I really hope that Australians do not let the fear of potentially imperfect solutions become a reason for doing harm.
Thank you. Bonnie, I wonder your reflections on marriage equality. your experience?
Yeah.
It's good.
Love is love, you know, everyone. Get it.
Are you going to leave it there? Yeah.
2017 was a great year. It was the year that Darlington Statement was also written, also the Uluru Statement from the Hart. It was a really cosmic time for those leaps forward in this country.
But I will say, if you are planning on voting no, I would like you to go to an Aboriginal person and look them in the eye and say no to them. Because it's just, you can't do that. Yeah. Anyways, thanks, Joe.
Historically, mental health responses were the sole domain of psychiatry, hospitals, sometimes general practitioners. But there is a movement in Australia to centre the expertise of people with a lived experience and peer-led services. Like, how do we empower people? And I'm going to go first to you, Bonnie, to talk about, because you know this is your wheelhouse, but to talk about it. But is like, how do we empower people to participate in mental health reform or policies that directly impact their life in a safe, meaningful, and most importantly, a powerful way, not a token way?
Well, I suppose from our point of view, from the intersex community, what we first did is we had to get people together in the same space and have some sense of consensus around what the issues were. And that happened organically through peer support spaces over the years and also the birth of the international human rights movement for intersex human rights. But then, you know, like, it's such a multi-pronged approach. Like, there's a real role for allies in terms of actually creating, in terms of helping create services that are appropriate for marginalised community members. Very much so, like the wisdom in terms of what the gaps in services are really do come through lived experience. If people have been disconnected from like evidence spaces, then they're never going to show up in like funded research. Even finding people through the, like, you know, private live studies or those types of things with intersex variations is really challenging because those people are hiding in community and their intersex variations have been erased a lot of the time. Or they don't use the term intersex, they use their diagnostic terminology, or they use different nomenclature like DSDs or disorders of sex development. So actually, in terms of crafting that, like having consensus, improving the knowledge in the sector so that there are meaningful referral pathways through to community-based supports is also an incredibly important thing. And that can involve just educating existing service providers, but also changing clinical culture to actually give up some of the medical authority over specialist ideals, or specialist kind of interventions that are directed towards people with intersex variations, to really hear consumer voices and to really bring community-based interventions into that environment so that they can work. Because community-based mental health interventions can do really different things than clinical-based interventions. Peer support is lifelong for many people. They can drop in and drop out of it whenever they need it if they have something come up. It's often much more affordable and it's much more nuanced, you know, like, because people really do have a sense of knowing what the particular circumstances and situations are. Our community groups can also connect people with really, like, they might have a really rare type of body and have been told by a clinical professional that they'll never meet anyone like them. But our peer-based networks, we're really connected, and so we have much more chance of being able to connect people with people that they will see who are like them and have that visibility recognised. And they're all really massively protective factors.
That is a great endorsement of peer support services. I hope people some public servants are jotting down. Maybe, not you, you're on the panel. Oh, you're a public servant too. Todd,
Joe.
lived experience. You know, nothing about us without us. Can we trust people to with a lived experience to be speaking about their mental health issues? And can we, should should our communities be involved in that?
Yeah, it's a challenging question because it's a challenging answer. Sometimes it's hard for some community members who are so deep in the throes of experiencing what they're experiencing that to pull them into a consultation and say, tell us how we're going to fix this, is just sometimes not appropriate. And we need to recognise that it's not that organisations or governments will go to people who are doing okay for their advice, but it's about recognising where we can pull the talents from. Because I think, Bonnie, what you're talking about are those the downstream drivers of how community can change things, where we also need to think about the upstream ways in which we can start teaching clinicians and medical doctors at universities what communities have learned, right? The medical curriculums in this country, particularly on LGBTIQ plus people, particularly on Aboriginal and Torres Strait Islander people, are abysmal. I mean, at the University of Melbourne, HIV and gay men are the only two things that link us. Yeah. Like, really? Nothing else but HIV? One of the best universities in the country. And so when we look at the drivers of how we're educating our new doctors and clinicians around really complex things that communities have known for a very long time, that have been sharing in both community resources and community research papers, aren't reaching the people. So we've got to catch them then on their third or fourth year in the hospital or in the clinic to be like, oh, actually, this model that you're doing is really doesn't work for our communities, or it's really unsafe. It's not responding to the intersections of power or race or culture or the geopolitical things that are happening in community. So there's multiple different ways that we can do that, but that doesn't mean we can't pull from community members who have a deep understanding of how the system works, who has a deep understanding of what it means to walk into a clinic and the receptionist doesn't recognise your gender identity, who know exactly what that feeling is like. But what is required is a strong complaints pathway where community members who have had that experience can be listened to, and where their experience of the service can be responded to in a way that has immediate effect, which is why the idea of pronoun badges works so well in responding to those complaints from a patient walking into a clinic.
Thanks, Todd. Michael, you're in the driver's seat, if I can say that, with the minister in the room. But you are the head of the National Suicide Prevention Office. How are you gonna, how's the office? We do it together in the public service. How are you gonna bring in the voices of lived experience?
Yeah, I have as you know probably by now, I have quite a structured mind, so I'll just approach it in the order that you presented, which is safe, meaningful, and powerful. And I think the first thing to start off with safe is that the reality is we cannot engage safely with people as long as stigma and discrimination remain a force. And so that means one approach of dealing with that is to have people like ourselves and everyone here present to actually go out and start speaking about their own lived experience of mental illness and suicidality. This community knows better than any other the power of visibility and the impact that letting people know that they're not alone, that their experience is common and normal and okay, and no barrier to success or love is really, really important. The second issue is around meaningful. And there I think there are a couple of things. To Todd's point, there is a lamentable tendency in governments and in policy development, and particularly in the Australian media, to continuously go to the same 3 or 4 people for commentary on mental health and suicidality. And we need to change this. We need to actually proactively reach into communities to identify those who are not seen and not heard. We need to do that from our own side. We can't wait for them to come forward. The second aspect of that is about the nature of representation. It's just not good enough to have 1 or 2 people on a board because the power dynamics are such that only the opinions and views that the majority approve of or agree to are allowed into the room. And so the net effect is that representation becomes tokenistic, apart from not even coming close to representing the diversity of the community. So you mentioned the NSPO. In the NSPO, what we're doing is we have actually 2 complete advisory boards. One is a quite standard advisory board, but we have a whole separate lived experience partnership. 14 individuals with lived experience across all different age, demographics, you name it, neurodiverse, culturally and linguistically diverse, Aboriginal and Torres Strait Islanders, rural and remote representatives, the whole caboodle. And they work separately to the board, but in parallel to govern all of the work of the NSPO. So it creates a very safe and very meaningful place to engage. And then on the last point, I think just about power and how we, what we do with engagement is that we need to ensure that it happens not just at one level, but at all levels. We need it in research, we need it in policy translation, we need it in government, we need it in commissioning, we need it in service design and delivery, because ultimately the whole point is to deliver services that are fit for the population that they're meant to serve.
But the challenge with that is going to look vastly different in every community.
Absolutely.
Like what needs to happen in Broome is going to be vastly different to Shepparton, vastly different to Hobart. And even within, because I agree with you so much, but even within that, we've got, LGBTIQ plus people can also be Aboriginal or multicultural or from a migrant or refugee background, living in regional, remote or metro. And those social, cultural factors are really, really important when we design the local strategies of how to implement services on the ground and how to respond to those communities, which, funnily enough, is why a voice structure just happens to work.
I also just think that, a lot of those structures already exist.
Yeah.
They exist within a community context, and those people have been doing that often voluntarily without any funding for,
And with
50
nobody
years,
listening.
And, so it's not about reinventing those structures because that puts other kind of well-funded organisations or government departments in competition with community groups sometimes. It's about nurturing what already exists there as like the mycelium of networks that hold together community.
Yep.
And know the individual responses, know the referral pathways within community, know what the triggers are in communities.
I'm going to ask you your last question, but before I do that, I want to recognise we're at Sydney World Pride, and I want to recognise that some of the things we talked about are very Australian-centric, but also when I talked about decriminalisation nationally in 1996, of course we have asylum seekers seeking asylum from countries where it is still the death penalty in their country, where it is still illegal, where you can't access gender affirmation care. And so I want to recognise that we have a role to play of looking at how we treat asylum seekers and opening up to LGBTIQA plus people seeking asylum, which not ironically, but we now have a situation where trans and gender diverse people may be seeking asylum from the United States. And so it's not just people in our region, but what is globally happening. So I just wanted to say that, because recognising we're really talking about Australian context, but of course there's a global audience and global issues, and we have people who've come from many different countries. Your last question today, and I'll see if we can go to questions from the audience. We'll see how we go. But I just want to say this is, these are, if in your opinion, if there was something that had to get done this year, to improve the mental health of LGBTIQA plus people, what would it be? And you can't have the national plan because we've got that. And I'm going to go first with mine, and mine would be that nationally we would have birth certificate reform in every single state that allows trans and gender diverse people to be able to affirm their gender without sterilising and invasive surgeries or sitting in front of a board. Just for I'm from Queensland. I am a transgender man. I cannot change my gender without invasive and sterilising surgery in Queensland. So that's mine, that we get that done. I'm going to throw to Michael.
Mine is very boring, but that's data. So we need to be collecting data about our community in all health and social service settings. We do not know what portion of the population identifies as LGBTIQ. Plus, we don't know where they live. We don't know what services they use. We don't know what issues affect them. You cannot design policies that are targeted to the right place at scale and to address the right issues if you don't know what the population is that you're serving. And the flow-on effect is you cannot achieve funding equity for those services because you just don't know.
Well, I would say if this year, if you could do it, then like nationwide legislation to protect children born with innate variations in sex characteristics from medically unnecessary and deferrable interventions, until they're able to take a fully informed part in that decision-making process. But that's always a two-tiered prong because you can't prohibit, and the prohibition's been necessary because clinicians have been self-regulating for many years and we've been asking them to change and they have been not changing. So that's been very necessary, but you need to also fund our peer-based services, both peer support and systemic advocacy, so that we can be more than just sitting at the end of the conveyor belt or at the bottom of the cliff catching people when they get spat out through a system that doesn't acknowledge the need that they have. So, yeah.
We need to reimagine our education curriculum nationally so that every school is a safe school.
Unfortunately, that brings us to the end because things have been running a little bit behind time, so we need to wrap up. I just want to finish by reminding you where we started, which is this has been a really heavy conversation with ideas that are not new to you, but some of the statistics can hit really hard, and you might be sitting with thinking of people that we've lost or your own thoughts. So I would encourage you to deliberately think about your mental health now, and whether you're at home or here, go outside if you can. Do something that makes you feel good, whatever that is. You are the best understander of your own mental health and what you need. But please do be deliberate about it. It's been heavy, but I think we all agree that it is very, very important. Now, please join me in...
Before you do that, can we thank Joe for making it incredible?
And the panel. And I'd like to just thank the Minister and his team and Jed Carney for being here to listen and hear what we've had to say. It's the first of many for 10 years.